who's been with us in PGI and is a very, very dynamic vitreoretinal surgeon. He's going to talk to us. Let's see what happens versus see microscope integrated OCT. I think Prasatul just now alluded to that. I think he's going to show you how it is helping us better in the surgical procedures. In the meantime, if there's any question you want to ask Prasatul.
Yeah, I'm ready.
Okay.
Thank you so much, Professor Dogra, for being making me a part of this IC. So I'll be talking on the microscopic integrated OCT. Let's see what happens versus see it happen. That means that once you operate these patients, whether you you operate them and then first post-op day or maybe later you'll find out that what have you left. So in all that, it helps a lot during your macular surgeries. This is one example I wanted to show, that this is a ERM which I have taken up for surgery. I have a mental picture of a epiretinal membrane, that it is a globally adherent or a locally adherent. I go to the OTN next and I operate this patient. Once I operate this patient, I know that this is a MIOCT, but I am not running it through the the lesion, because I wanted to show that what happens if you don't do what can happen if you don't use the OCT. So I am doing a regular PVD induction, and then it seems that I have done the job, and probably now I'll finish the peripheral vitrectomy and close the case. And this can so if I don't use a OCT here, that this thing can happen, that now I run a OCT through the lesion, intraoperative OCT. You can see a residual membrane there still left, and the foveal contour is not back. And then this is where the advantage of OCT comes. And then you see that now I know that some people will challenge that I will do ILM peeling in every patient, then there will be no membrane left. So I say that I won't do a membrane peeling, I won't subject this to ILM. I'll just look at the this thing, the intraoperative OCT, and then peel this membrane. And this is how it will look like after I've peeled the membrane. So intraoperatively, I've known that this would have happened if I have not used the intraoperative OCT. This is the major advantage of intraoperative OCT, to complete, whether we have done the complete peeling. This peeling could be in a ERM, this peeling could be in a diabetic, this peeling could be in a myopic retinoschisis. It helps everywhere. Whether you have tucked in properly, because nowadays we are tucking in so many things inside. We're tucking in scleral plugs, we are tucking in the ILMs, we are tucking in the neurosensory retina. So you want to know exactly whether you have tucked it at the proper place or not. I'll show you the example, whether we are injecting in the right plane, like Sir showed the TPA. In future, we will be injecting gene therapies. We should not be injecting them into the intravitreous. We want to tuck them properly in the sub-RP space. So this is where it is going to help us. Rapid localization, area of interest, immediate feedback. There is hardly any lag we can feel. It provides a visualization of the instrument tissue interaction, and this is how it looks when I'm operating through a SOM. Now the people use the standard operating microscope. This is SOM now, and this is how it looks like. And it can be disturbing in initially few dozen or maybe 25 patient cases, but later on it is not. Once you are done with the OCT, you can switch it off and you can move on to your this thing. So it will not stay there for all the time of the surgery. It will just come there whenever you want it. So you click a foot switch, or tell the bring in the OCT, it will bring it. You will see it whether you are removing the membrane or not, and you can, moment you don't want it, you can take it away. And this is how it has been integrated into the 3D systems also, because this is not this is by different companies, so it is not, the resolution is not coming that well, but people are working on making into a digital platform also. So as I've already said, macular hole, epiretinal membrane, dioptic traction, therapeutic, and this is one case where I'll show the tucking there, how it helps there in the tucking. So this was a case with a large macular hole with a RD also there. So taking a neurosensory retina was immediate thought that why not tuck it. So I went ahead and brought a neurosensory retina from supero nasal area. This is the retina lying there under the PFCL, and you can see that how the OCT is helping me that I am going into a right place, and that whether this is tuck-in is complete or not. So this is how a microscopic OCT will tell us that whether you have done a right surgery or not. This is how it helps. And this is what you can see, that this is how the post-op also you can follow up these patients, that whether your tuck is incomplete, whether your sensory retina was smaller or bigger. You don't want to be a smaller one, or you don't want to be a too bigger one. So you can ideally, the people are still working on it, what kind of, how much, 25% they should take more or 55%. This is just like the optical graft we have to take, whether we take a 7.5, 7.25. So people are working on the punch biopsies also. There are so many things happening in this part also. And this is what the diabetic, vitrectomy looks like. For me, any diabetic vitrectomy I'm doing, I will have to do an intraoperative OCT in the end to see whether there is any residual membrane left or not. I used to run it intraoperatively also most of the time. So you can see the membranes are being cut. You can see this, I can see there's a place between the retina and the membrane. So my cutter will go in. You see this, I have caused, this kind of a, my cutter is just cutting the membrane, not the macula. Now I know that there is a fine membrane there. I can see it in the OCT. I'll go in and grasp it over the desk and just take it out. And till the time I don't see, though I need not unnecessarily stain with ILM and remove ILM, because which may lead to issues there. Everybody is not doing ILM peeling in routinely in these patients, and this will be the end of the any diabetic vitrectomy where I am doing it for the posterior pole in such patients. And this is what I do it regularly for. And again, this is a myopic patient with a large macular hole. So I have stained it. I know that, but I just wanted to tell was because the biopsies are difficult eyes, you must stain them to see the ILM properly. But whether we have tucked this ILM properly into that large macular hole or not, that can be helped with the MIOCT, and it's very nicely seen when you're tucking it. And see the membrane there, which is very nicely come over it, and you know that you have done a good job, and you can always close this case once you have brought ILM over the large macular hole, and you be assured that even you can, after the fluid gas exchange, you can see that whether it's staying at the same place or not. I think this is what Dr. Atul has already showed, that TPA, whenever you're injecting, whether you are in the right plane. So like with the gene therapy also we'll be doing in the future. So you will see me injecting TPA, and intraoperative OCT will be running along with. You will see I'll be inducing RD there, and which will be showing that yes, this fluid, this TPA is going to the right place. You just keep your focus on this side. You will see this RD getting induced. See, the fluid is going in. This is RD is getting induced. So this is where the intraoperative OCT is right in front of your eyes, telling you that you have injected the TPA or gene therapy in the future into the right place or not, with the MIOCT there. And then this is, I think Mohit will be showing this. This is his video. And again, whenever you want to take a biopsy there, you have a lesion which is suspected of lymphoma, and there was a peripheral lesion also, and you can with your green tip, and which can be you can literally see whether you have gone to the right plane also. And this is a still from that video, that because green tip is not is not blocking the rays there, so you can see the cells moving into the green tip. But this is how you can know that whether you have taken the nice yield of the tissue or not, so that you can send it for the biopsy there. And Mohit will be showing more of these videos there. So where it doesn't help much, there are issues there, because I have already said the instruments are not the friendly, because they cause a back shadow, and then it doesn't work for a myopia more than 10 diopters, and the resolution surprises are always there. And this was a patient with -28. I really wanted that OCT should help me here, but the view was not very clear. So there are some limitations of this thing still there. And again, I showed you this is our standard the spectral domain or SSOCT, and this is how it looks intraoperatively. So don't worry about that. The people are working on the resolution, but the resolution of intraoperative is still less what we have in the OCT in the office there. So we are looking forward for the improvement in the resolution and depth, integration into the heads-up vitrectomy, like sir has already said, there are digital systems. We want incorporation into that also, and the intraoperative OCT software, so many things people are working on the MIOCT there nowadays. Thank you.
Thank you, Raman, for excellent talk.